One of the most common concerns I hear as a spine surgeon is, my feet are numb. Is this coming from my back? Sometimes the answer is yes, but very often, particularly when the symptoms affect both feet, the problem is not a pinched nerve in the spine. It can actually be peripheral neuropathy. So today, I want to explain what peripheral neuropathy is, why it commonly begins in the feet, what can cause it, how we can distinguish it from a spine problem, and what you can do about it. This presentation is educational and cannot replace an evaluation from your own clinician. Let's begin with the main message. If both feet are gradually becoming numb or tingly, the symptoms are often caused by peripheral neuropathy rather than a condition requiring spine surgery. That doesn't mean the symptoms should be ignored. It just means that we need to ask the right questions and investigate the right part of the nervous system. The pattern of the symptoms often provides our first important clue. Think of your nerves as the electrical wiring of your body. Your brain and spinal cord form the central nervous system, or the main control center. The peripheral nerves are the smaller wires that travel all the way to your arms, hands, legs, feet, and also internal organs. They carry the information in both directions, and they also allow your brain to feel what is happening at your feet, and they carry instructions from your brain to your muscles. When those peripheral nerves become damaged, their signal can become weak, distorted, or completely interrupted. Peripheral nerves perform three broad jobs. You have sensory nerves that are the ones that allow us to feel touch, temperature, pain, pressure, and the position of your feet. That's called proprioception. When these nerves are affected, people may experience numbness, tingling, burning, electric shocks, or problems with balance because they have difficulty perceiving where their legs or arms are in space. Motor nerves are the ones that control muscle movement. So damage to these type of nerves can eventually lead to weakness, cramping, or difficulty lifting the foot. Autonomic nerves, those are the ones that control the functions that we do not consciously think about, such as blood pressure, sweating, and digestion. Sensory symptoms are often the first ones that patients notice. You may ask, why does neuropathy so often begin in the feet? The nerves traveling to the toes are among the longest nerve cells in the body. Some extend approximately 3 feet from the spinal cord to the toes. The farther a nerve must travel, the more structure it has to maintain. Think of it as a highway. So those long nerve fibers are therefore especially vulnerable to problems involving metabolism, nutrition, toxins, or blood supply. That is why neuropathy commonly begins at the toes before affecting areas closer to the body. The classic pattern begins in the toes, in both feet, and gradually moves upwards in the legs. We call this a stocking pattern because it can eventually affect the area that would be covered by a sock or stocking. Small nerve fibers are more closely associated with burning, stabbing, or electric pain. Large nerve fibers help with vibration, position, and balance, so damage there may feel more like numbness or unsteadiness. This pattern is very helpful, but is not a diagnosis by itself. An examination is still necessary. Peripheral neuropathy is not one single disease. It is a description of nerve damage, and more than 200 conditions have been associated with it. Fortunately, we can organize most causes into a few groups: metabolic conditions, nutritional problems, toxins and medications, immune diseases, abnormal blood proteins, inherited conditions, and infections. I will briefly walk through the most important causes. The goal is not for you to try and memorize them. The goal is to show you why a thoughtful evaluation is always so important. Diabetes is the most common recognized cause of peripheral neuropathy. Over time, elevated blood sugar and the metabolic changes that accompany diabetes can damage nerves and the small blood vessels that support them. Approximately 1 in 3 to 1 in 4 people with diabetes develop neuropathy, depending on the population and how neuropathy is measured. This is one reason that controlling blood sugar is about more than just keeping a nice laboratory number. It helps protect nerves, blood vessels, kidneys, eyes, and other organs. That's where many times in patients with poorly controlled diabetes, year over year, they can start developing more complications because of the cumulative damage to all the organs. Importantly, nerve symptoms may sometimes begin before someone has been formally diagnosed with diabetes. This is very important. Prediabetes, excess weight, elevated triglycerides, and other metabolic risk factors can be associated with nerve problems. This doesn't mean that everyone with tingling has prediabetes. It means that blood sugar and metabolic health deserve attention, even when a person has never been told they have diabetes. In some patients, numbness in the feet is an early warning that leads us to identify a larger health issue. Other body-wide medical conditions can also affect the nerves. Advanced kidney disease can allow substances to accumulate in the blood that are harmful to the nerves, because with advanced kidney disease, basically your body has difficulty getting rid of toxic substances. An underactive thyroid can sometimes also contribute to neuropathy. The encouraging part is that kidney function and thyroid function can be assessed with routine blood tests. These are common and relatively straightforward parts of the evaluation. Vitamin problems can be confusing because both too little and too much of it can be harmful. Low vitamin 12 can damage the nerves. Risk factors for it include pernicious anemia, prior bariatric surgery, strict vegan diets, and long-term use of medicines such as metformin or acid-reducing medications. Vitamin B6 presents the opposite problem. High doses, often through supplementation, can also lead to damage in the nerves. This is why your clinician needs to know about every vitamin and supplement you take, not just your prescription medications, because over-the-counter doesn't always mean that it's harmless or safe. This is an important one. Regular heavy alcohol use is an important cause of neuropathy. Alcohol can directly affect the nerves, and it can also contribute indirectly through poor nutrition or vitamin deficiencies. Patients sometimes underestimate their intake because they do not realize that the amount of frequency is medically relevant, right? Like you get used to having a few drinks every night, but then this may be leading to some nerve damage. The purpose of asking about alcohol is not to judge anyone. An accurate history helps identify a potentially treatable contributor and allows alcohol to be reduced safely when is needed. There's also certain medications that can affect the peripheral nerves. Example of this include some chemotherapy treatments, heart medication, amiodarone, and certain antibiotics. This doesn't mean that everyone taking any of these medications will develop neuropathy. It also does not mean that you should stop a prescribed medication on your own. Instead, bring your complete medication and supplement list to your appointment. Your clinician can review the timing, the dose, any potential alternatives, and the risk and benefits of making a change, because sometimes you do have some neuropathy, but the benefits of having that medication, let's say in the case of a chemotherapy medication, sometimes the benefits will outweigh the risks. Less commonly, the immune system can attack or inflame nerves. Example includes vasculitis, Sjogren's syndrome, and sarcoidosis. These conditions often produce patterns that are different from the slow systemic numbness seen with typical diabetic neuropathy. They many times can progress more quickly, cause substantial weakness, or affect the nerves unevenly. They are important to recognize because some immune-related neuropathies can improve with targeted treatment for the condition that is underlying this problem. Some people with neuropathy have an abnormal protein circulating in the blood. These proteins become more common as we age. Many are harmless and simply need observation, but some require further evaluation. A blood test can look for these proteins. Finding ones does not automatically mean cancer or another serious disease. It just means that the results should be interpreted in the context of the person's symptoms, examination, and other laboratory findings. There's also some neuropathies that are inherited. The most common inherited form is called Charcot-Marie-Tooth disease. Clues can include very high arches in the feet, hammer toes, long-standing ankle weakness, difficulty running earlier in life, or relative with similar problems. Because the changes often develop gradually, some people do not realize that their foot shape or weakness could be related to an inherited nerve condition. Family history, therefore, can be very valuable. Then there is a smaller group of neuropathies that are associated with infections. Examples include HIV, hepatitis C, and leprosy, which remains an important cause in some parts of the world, but not as much in the US. Sometimes the infection directly affects the nerves. In other cases, the immune response or a treatment for the infection may be what contributes to the neuropathy. Testing is guided by a person's medical history, risk factors, travel, symptoms, and examination. Not every patient needs every possible test. Even after a thorough evaluation, no definitive cause is found in up to approximately 1 in 4 patients. That can be very frustrating, but no identified cause doesn't mean that nothing can be done. Many unexplained neuropathies progress slowly. We can still treat painful symptoms, improve balance and strength, reduce fatal risk, and protect the feet that have lost sensation. We should continue to monitor the pattern because a changing pattern may provide new clues over time. Now, let's return to the original question. Is the numbness coming from the back? A pinched spinal nerve commonly affects one side and follows the path of a particular nerve down the leg. It may occur with back pain, shooting leg pain, or weakness in a specific muscle group. This is one of the main differentiators. Nerve pain and symptoms tend to be very specific. Peripheral neuropathy, on the other hand, more commonly affects both feet in a relatively symmetric pattern, begins in the feet and then moves upwards. These are typical patterns, not absolute rules. A person can have both spinal disease and peripheral neuropathy at the same time. The examination helps determine which condition is producing which symptom. Most importantly, symmetric numbness in both feet usually is not by itself a surgical spine problem. Although most gradually developing numbness is not an emergency, there are some symptoms that cannot wait. You should call 911 or go to an emergency department for any new loss of bladder or bowel control, numbness around the groin, rapidly worsening weakness or difficulty walking, or sudden one-sided numbness accompanied by facial drooping or slurred speech, because this may mean stroke. These symptoms may indicate serious compression of the nerves at the bottom of the spine or a stroke again. Do not wait for a routine clinic appointment when these warning signs are present. Other patterns may not require an ambulance, but they should still be evaluated promptly. You should contact your clinician if the symptoms develop over a few days to a couple weeks rather than months to years, if they are one-sided or markedly uneven, or if weakness is more prominent than the numbness. Fever, rash, unexplained weight loss, fainting, or significant lightheadedness when standing are also reasons to seek timely evaluation. These features can point towards inflammation, infection, autonomic nerve involvement, or another condition requiring more urgent testing. The evaluation usually begins with the least complicated and most valuable tools, which is your history and focused physical examination. Your physician will assess your ability to feel light touch, sharp sensation, temperature, and vibration. They will also examine the reflexes, muscle strength, walking, coordination, and balance. Lastly, you also look at the distribution. Are the symptoms limited to one nerve? Are both feet affected equally? Do they stop at the ankles or they extend farther upward? These findings help decide which tests are actually necessary. Several blood tests are especially useful. Your physician will commonly check blood sugar or hemoglobin A1C, which provides an estimate of average blood sugar over the previous several months. They may check vitamin 12 and may also add methylmalonic acid, which can uncover a functional B12 deficiency that is not obvious from the B12 alone. A blood protein test, often called SPEP or SPEP, with immunofixation, looks for abnormal proteins in your blood. Kidney function, thyroid function, and additional tests are selected based on a person's individual history and examination. Not everyone needs electrical nerve testing, but in some cases it can be very helpful when the diagnosis is uncertain. Nerve conduction studies measure how well the signal travels through the nerves. Electromyography, or EMG, evaluates the electrical activity in the muscles. Together, these tests can identify large fiber nerve damage and help distinguish peripheral neuropathy from a radiculopathy or pinched nerve. Small fiber neuropathy can be much more difficult because nerve conduction studies may be normal even when a small fiber neuropathy is present. In selected cases, specialized testing and sometimes a small skin biopsy may be considered by your physician. Treatment begins with addressing the cause whenever possible. If blood sugar is elevated, improving glucose and metabolic health matters. If vitamin B12 is low, your physician may replace it. If excess vitamin B6 is the problem, the supplement should be stopped and the dose reviewed with your physician. Alcohol should be reduced safely, particularly if there is a risk of withdrawal, and immune conditions may require treatment of the inflammation. A potentially responsible medication should be reviewed with the prescribing clinician, not stopped independently. And remember, nerves heal slowly, and some damage may not fully reverse. That is why identifying and treating the cause early is very important. We can also treat the symptoms, especially burning, shooting, or electric nerve pain. Medicines such as gabapentin, pregabalin, duloxetine, amitriptyline, and certain topical treatments may help. The best choice depends on other medical conditions you may have, possible side effects, the cost, and how the symptoms affect sleep and daily activities. These medicines can reduce the pain, but they generally do not restore sensation or reverse the nerve damage. Physical therapy, balance exercises, and appropriate strength training are also very important, particularly when numbness is affecting walking or increasing the fall risk. When sensation is reduced, a small blister, cut, burn, or pressure sore may go unnoticed. So check your feet every day, including the soles and between the toes. If it is difficult to see the bottom of the foot, use a mirror or ask someone for assistance. Avoid walking barefoot, wear shoes that fit properly, and check inside of them for stones or any areas that are rough before you put them on. Test bath water with your hand or elbow rather than relying on a numb foot, and report wounds, redness, swelling, or sores early, especially if you have diabetes or circulation problems, because what can happen many times is that you develop a small wound, it doesn't hurt, right? You cannot feel it, and that wound can slowly worsen, and by the time that you realize it, maybe a really bad infection. So you have to keep a really close eye on your feet when the sensation is altered. So let me leave you with 3 main points. First, numbness that begins in the toes of both feet and gradually moves upwards often suggests peripheral neuropathy rather than a single pinched nerve in the spine. Second, there are many possible causes, and several are treatable. A careful history examination and a focused set of blood tests can often identify the cause or guide the next step. Third, even when the cause cannot be completely reversed, we can treat the pain, improve balance, reduce falls, and protect the feet. If you are preparing for an appointment, make sure to bring your physician a timeline of when the symptoms started and how they changed. Note whether one foot or both feet are involved. Bring every medication and supplement you take, and be ready to discuss alcohol use and family history honestly. Numbness in your feet is worth checking, but it does not automatically mean you need spine surgery. Many times after a thorough evaluation, your physician, if they have any concerns, will refer you to a spine surgeon for further assessment if they feel like your spine may be involved. These are the selected medical sources used for this presentation, and I'm happy to take any questions in the comments. If you enjoyed this video, please subscribe, and I'll see you on the next one.